All right. Great. Okay, so good evening, everybody, and thank you so much for being here. I'm Ruth Nickens. I'm the Health and Wellness Program Coordinator at this Tallahassee Senior Center. And as you know, tonight we're presenting another mental health awareness event. This is our 4th annual event, and tonight's topic is going to be the invisible epidemic, substance abuse in older adults. Just a little bit of housekeeping before we get started. I want to thank Acadia for helping us out by setting up the CEUs, and also I want to thank Capital Regional for always being so supportive and also being a liaison to help bring on Dr. Ferraro to this presentation tonight. Again, the CEU information is up here now. I will also type that into the chat when we're rolling so that people who are joining us later can also have that information. Karen, would you like to say a word or two about your organization?
Sure. Thank you, Ruth. I'm Karen Kramer. I work with Acadia Healthcare, who, as Ruth mentioned, is providing the CEs for tonight's presentation. So happy to do that for you all. I work as a treatment placement specialist with Acadia Healthcare. So I work with providers and their clients and family members looking for residential care. So for any types of mental health diagnoses, could be any kind of mental health. So mood disorders, substance use disorders, issues with trauma, PTSD, chronic pain, disordered eating. So a lot of different types of mental health diagnoses. And we have lots of different facilities. We have close to 300 different facilities nationwide, which includes the residential programs as well as hospitals across the nation. So like I said, I'm a resource to you in looking for residential care and working with you and the families. So.
Thank you so much, Karen. I'm going to introduce Melanie and let her talk about Upside, and then I'll introduce Kelly, who will then introduce Dr. Ferraro. So Melanie Lachman is with us. She is the Upside Program Coordinator at the Tallahassee Senior Center. And this program, Upside, is always a partner in this program because it's part of how we at the Senior Center have really been focusing in on mental health issues over the last couple of years. So Melanie, take it away.
Thank you. Just let me know if you can hear me or anything. So UPSLIDE stands for Utilizing and Promoting Social Engagement for Loneliness, Isolation, and Depression in the Elderly. And we do that in a number of ways. But before I get to that, I just want to give a short blurb about why it's important to combat loneliness, isolation, and depression. Before we had this pandemic, it was being recognized that loneliness and isolation are public health problems. So the physical effects are equal to those of smoking 15 cigarettes a day. It increases our odds of getting dementia. It increases our risk of dying early. And it also puts us at risk for substance abuse and substance use disorders. So there's a whole bunch of negative effects that happen when we are lonely and isolated for a long time. So UPSLIDE seeks to combat that, and we do that in a number of ways. We have individual counseling support at no cost to our participants, for example. So we help folks manage anxiety, depression, give them guidance in establishing and maintaining relationships, just holding their hands and helping them find activities, be it at the senior center, out in the community, whatever it is. We're gonna figure out what it is people wanna do and help them to do it. And we also provide education with regard to whatever they're experiencing, be it anxiety or depression or whatever it is. But where the true magic happens, and I know that's sort of like a trite thing to say, but it is honestly true, is in our Friends Connection groups. And we have groups that meet in person twice a week at the Senior Center, one that meets weekly virtually. We've continued that. We've also increased how often it meets since opening up again. We have a group that meets at the Lincoln Neighborhood Center, one that meets way out at the Miccosukee Community Center. And this is where people meet, where friendships are created. They're the warmest and most welcoming and wonderful group of people. We just try to have fun. We talk about deep things. We share deep things, but ultimately we have fun. And we have some sort of upslide only things that we do. We do monthly game days. We're going to start doing field trips and outings at some point again when that is safe to do. We help people with transportation, helping people fill out dial-a-ride applications, give people dial-a-ride tokens so they can come to us. We're trying to make it as easy as possible for people to come and get involved and have more people in their lives. So if you or anyone you know, any questions, you can always, well, 89, you can
Type it in the-
call. I'll chat.
We'll type it in the
I'll chat
chat
my
box.
So we'd love to have you. We just love having new people, and that's Upslide.
Thank you. And most importantly is we do accept referrals. We encourage referrals from physicians and other agencies and organizations. So keep that in mind, Dr. Ferraro. So Kelly, I'm going to turn it over to you to introduce yourself and to introduce our guest speaker. Thank you again, Capital Regional. I have felt like mental health was just such an important issue in the last few years, especially the last 2 years. And we have brought to the forefront some very challenging and difficult to talk about topics in the last 4 years, including suicide and sexuality, PTSD, trauma. And so we're really delighted this year to be able to talk about substance abuse. It's a huge issue, and we're going to learn all about that and how it's even gotten worse over the pandemic. Anyway, it's all yours, Kelly. Thank you again.
So thanks again, Ruth, for asking us to speak. It's always wonderful to work with the Senior Center. As you mentioned, we've done a lot of presentations over the last 6 years. And so anyway, so this is just another exciting opportunity to share a little more information. Again, I'm Kelly Mercer. I'm the Program Director for Behavioral Health at Capital Regional. We offer a variety of services. Real quickly, I'll kind of briefly go over those before we get started with the presentation. We offer an inpatient adult unit on the 7th floor of the hospital. It's a beautiful unit. It's been open about 6 years. So lovely program. If you or someone you know is struggling with a mental health crisis, please come to the emergency room. We'll be happy to talk to you and get you into the program. We offer music therapy, art therapy. Visitors should be returning to the hospital soon, so we'll have pet therapy again. We have a wonderful program. And so again, if you know someone who's struggling and in true crisis, please again come to the emergency room and we'll be happy to help. Our outpatient program is not traditional outpatient. It's called intensive outpatient or a partial hospitalization program. But essentially it's a group therapy based program where individuals come for a half day or a full day of group therapy. They have access to our physician, and at the end of the day, they go home, they sleep in their own bed, they're with their family, etc., and they come back to us the next day. So it is a program, but it is not forever. Individuals are with us 3 to 5 days a week for 3, 4, 5, 6 weeks. It just again depends on how they're doing. So again, wonderful program. We have specialized programs within that larger outpatient program for adult mental health, adult substance abuse. And we actually have a university specific intensive outpatient for those of you who have loved ones in college. It's actually a second location for us over near FSU, but open to any college student. And then we have our adolescent intensive outpatient, which opened in April of 2020. So for ages 13 to 17. So a variety of services. We take most insurances for that program, and we do a free initial assessment for all of our outpatient services. So I always tell people, if you have a loved one who is struggling and they're not quite sure where they fit in or if it might be a good fit for them, it is absolutely worth coming in for that free initial assessment to see if it might be a good fit for you. There's no obligation. It's voluntary, very non-threatening situation. So if you're not sure, it's worth just coming in just to check it out. So if you have questions, I'll put our contact information in the chat if you have questions specific to the program. So feel free to reach out to us. And so I'm going to
yes. Kelly, let me just mention to everyone that we will have time for questions and answers at the end. So you can either chat them into the chat box or just hold your questions to the end. And Melanie, if you could kindly monitor that chat box, that would be super helpful. Thank you.
Thank you, Ruth. So I'm going to introduce Dr. Ferraro. He's been with us almost 2 years. His 2-year anniversary with us is coming up. So we're super excited to work with him. He is our medical director. He has a slew of physicians who are amazing that work with us. And I'm actually going to let him tell you a little bit more about his background and his passion for substance abuse. So thank you so much.
All right. Well, thank you very much, Kelly. Once again, pleasure to be here and to be able to talk about something that is near and dear to my heart. I work at Capital Regional Medical Center, and like Kelly was saying, involved with the inpatient work and our outpatient programs, in addition to a substance abuse program that we have at Capital Regional, which is an intensive outpatient program. And, board certified in addiction medicine as well as psychiatry, and really got my interest in addiction medicine when I was doing my residency at the University of Florida, where we got to see a lot of different patients that were struggling with addiction and a lot of different age groups, as well as people at different stages of their careers, and get them back on track. So I want to make it as interactive as possible. I know it's a little bit difficult on Zoom, not being in person, but we'll try to do our best here. Just starting off with an overview of substance abuse in the geriatric population. We're going to talk a lot about the baby boomer generation and the impact that that's had on substance abuse rates in the United States, and some of the factors that have played into that. First off, the baby boomer generation is going to be the largest group of older persons in the history of the United States. So in 2011, the first baby boomers turned 65, and that number is going to continue to grow until 2030, where we'll have approximately 72.5 geriatric patients in the United States. So that's a significant percentage of our population. Compared to previous cohorts, the baby boomer generation has had higher rates of early substance abuse. So starting earlier with their substance abuse history. Their lifetime rates of use of illicit substances are 47.4% compared with previous generations, which were 19.3%. So you can see over a twofold increase in their lifetime history of substance use. As the baby boomers get older, they're bringing their substance abuse issues with them into their older years. And it's felt that the absolute number of people with substance abuse is going to expect to grow across all genders and racial and ethnic groups as we get into the middle half of this century. It's been felt that the rates of substance abuse is going to increase in older individuals, and it's supposed to more than double from 2.8 million in 2006 to an estimated 5.7 million older adults in 2020 struggling with substance abuse. So in fact, the substance abuse population and the geriatric substance abuse population is one of the fastest growing health concerns within the United States. We can go to the next slide. So this is a nice slide that talks a little bit about comparing over the last 100 years, 1960 compared to another 100 years, what our population is going to look like. And you can see that in 1960, we had a pyramid population where you had a very, very small percentage of people relative to the overall population that were 65 and above. Whereas you can see it's more of a column now, in that the 65 and older is just as many people than the younger generations. So people are living longer. There's a lot of different reasons for that, but you can see just the overwhelming number of people that are living, past the age of 65 in the United States. We can go to the next slide. So I don't know if anybody was here for this, but this is the generation we're talking about, baby boomer generation. This is Woodstock, and the people in this picture are the youngest they would probably be 70 years old right now. So this was, I think, 1968, 1969. All right, we can go to the next picture. So talk a little bit about epidemiology. The true incidence and prevalence of substance use disorders in the United States population is not known. And there's many different reasons for this. When you look at the literature, substance abuse does not have a uniform definition within the scientific literature. There's many different diagnoses that different studies use. whether or not they use the DSM-4, the DSM-5, or individual substance abuse scales. There's also many different terms that's used in the literature. So abuse, dependence, misuse, use disorder, all confound the studies. So it's very hard to get an exact prevalence or incidence of substance abuse. However, it's universal that most of the people in addiction medicine would feel that the presence of substance abuse disorders that are diagnosed in this population are often underestimated, underidentified, underdiagnosed, and undertreated. So further research is needed in order to really get a better understanding of the true prevalence and moving forward into different forms of treatment. Risk factors. There's several risk factors that have been discussed to explain the higher numbers of substance abuse disorders in this population. The first one we talked about briefly, comparing the pyramid to the column of the population growth that's occurred in the older generations. So just in general, there's higher population of older individuals. In addition, higher life expectancy, which is secondary to medical breakthroughs. Also, it's been postulated that the baby boomer generation had a heightened sense of desire for personal gratification. So they were more egocentric as compared to some of the other generations that may be less likely to be involved with personal gratification. They also had higher rates of drug use whenever they were growing up. And like I said before, that carried into their adult years. They had also, this is a population that relative to other populations, maybe the silent generation or the greatest generation, so to speak, when we're looking back in history, it's a much healthier generation due to various lifestyle changes that have occurred over the years, in addition to advances in medicine. Cultural changes as well occurred with this cohort. This population led the civil rights movement, the gay rights movement, the feminist movement, the Vietnam protests, the sexual revolution, and all of this had a very profound effect on their perception of drug use, and really did change the perception within the United States. So kind of shifting on to various risk factors. They're kind of outlined there. Some of these risk factors are very similar to the risk factors for suicide, but just to kind of go on an overview, being male, white or black race, having higher education, high school education or beyond, risk factor. Unmarried or divorced. We had talked a little bit earlier in the presentation about loneliness in isolation, which is certainly highlighted in these times. Depression, bereavement, mental health issues increase the risk for substance abuse. Chronic physical illness, which is what we're going to see in this population. Disability, social isolation, being a caregiver for a loved one or a spouse. Change in your living situation. People may be uprooted given their physical ailments and have to live with children or grandchildren in another city or a town that they may not be familiar with. And those that are not religiously active, it's felt that those are all risk factors for substance abuse in the older generations. And those are just some pictures. Loneliness, and then the picture on the bottom right, the lady. I think we can all identify with this. Seeing patients that may have 5 or 6 psychiatric medications and maybe 10 or 12 different medical medications. It's very, very difficult to not only keep all these straight as far as when to take them, what they're for, but more importantly, if you look at the picture to the left, when you mix it with any type of illicit substance or alcohol, it can have catastrophic outcomes. So we go to the next slide. So medical complications, there's a whole slew of medical complications that occur with substance abuse in the elderly population. Older people with drug dependence have higher rates of medical comorbidities, such as high blood pressure, liver disease, body pain, decreased physical functioning compared to their younger cohort of substance abuse population. Individuals also with substance use issues have a younger median age of death, and people with substance abuse die on average 22.5 years earlier than people of the same generation that do not have substance abuse issues. They're also at risk for developing neurotoxicity, and we can see age-related changes in the brain, which alter drug metabolism, pharmacokinetics, and contribute to this population's vulnerability to neurotoxicity. Like we were talking before, all of these illicit substances can cross-react with the medications that they're being prescribed. So just a little bit of alcohol mixed with the medications that they're currently being prescribed by their primary care physician or cardiologist could have significant adverse outcomes. So I wanted to kind of go into just some of the different substances that we do see being used in the geriatric population. And we can go to the next slide, and I think that's going to be alcohol. Okay, so before we get to that, you can see people over the age of 50. The pie graph on the left is males, and the one on the right is females. And almost 50% of people over the age of 50 have claimed that they've used marijuana within the past year. About 25% of males will use prescription drugs for non-medical reasons. And then you can see that the numbers are fairly similar. A lot more females will be using illicit prescription drugs compared to their male counterparts. And we can go to the next slide. So let's talk a little bit about alcohol. Important to talk a little bit about the physiology of the geriatric population in regards to alcohol. With aging, the body undergoes numerous physiologic changes, including decreased percentage of lean body mass, decreased total body water, diminished ability of the liver to metabolize alcohol. And why that's important is, compared to younger populations, somebody in their 20s or 30s, the geriatric population will have a higher blood alcohol content per drink compared to younger populations. So that's fairly significant. You know, whenever somebody would have a glass of wine in their 60s, 70s, and 80s, it's much more significant in regards to its effects on the body compared to someone in their 20s or 30s. Once again, mixing alcohol with any medicines that you're being prescribed can significantly increase the chance for drug interactions, increase risk for intracranial hemorrhages, impaired activities of daily living. And we talked a little bit about neurotoxicity. Older individuals who consumed alcohol are at increased risk for cognitive impairment. About 78% of people that were diagnosed with alcoholism did have evidence of brain pathology at the time of death. So significant changes will occur in the brains of people that are alcohol dependent. We can kind of switch over to another substance that is certainly very important. Although not illicit, it causes more deaths in the United States than any other substance. It's been well documented, the harmful effects of tobacco. Estimated that about 20 million people over the past 50 years have died as a result of tobacco use. And there's a whole host of medical comorbidities that are associated with smoking. Increased mortality, high blood pressure, atherosclerosis, strokes, decline in pulmonary function, development of osteoporosis, risk of hip fractures, loss of mobility, and just overall poor physical functioning. The important thing is, you know, if somebody has a history of smoking, not to lose hope, in the sense that it's been shown that cessation of smoking in older individuals is also associated with reduced risks in myocardial infarctions, strokes, as well as improved lung functioning. So, there's always a time to quit, and we do see benefits even after somebody does quit, even within the short term, within the first 3 to 6 months, especially in lung function. Going to marijuana. Marijuana is interesting because states have adopted different policies in regards to recreational use versus the use of marijuana from a medical standpoint. And a lot of the medical illnesses that the geriatric population may be struggling with may lend itself to medical marijuana. However, marijuana is not risk-free, particularly in older individuals. Use of marijuana does increase the heart rate as well as the respiratory rate and blood pressure. And there's been shown to be a 4-fold increase in the risk of cardiac events within the first hour of ingestion. So that's something to be aware of, that marijuana, because of its effects on the cardiovascular system, can be very dangerous in the elderly population, especially those with cardiac illness or history of high blood pressure. It's also associated, as we well know, that with short-term memory impairments, and this can exacerbate people that may have a mild cognitive disorder or the emergence of Alzheimer's disease. So, the combination of marijuana and any of those dementing processes would certainly affect short-term memory in addition to the underlying disease. Next, so this is an interesting slide. And these numbers have actually gone up since 2013. But you can see, just looking at the different populations, the millennials in 2013, 65% of them support legalization of marijuana. Gen X is about 54%, and the baby boomer generation is 50%, which is pretty much equivalent to what it was in the late 1970s. So you can see that the baby boomer generation, which is probably the best indicator for current geriatric use, has there was really a trough there in the early 1990s, where about 17% of people in that generation supported the legalization of marijuana, and now it's gone up to 50%. And like I said, those numbers have continued to go up incrementally since 2013. So there's certainly more support out there. In regards to cocaine, once again, like alcohol and tobacco, we know the harmful effects of cocaine, but these are all amplified in the geriatric population. It's associated in the elderly with cardiovascular disease, specifically left ventricular hypertrophy, which is basically when the muscles in the left heart chamber become very big and are less efficient in pumping blood. It also can result in cerebrovascular accidents, strokes, subarachnoid hemorrhages, aneurysms, bleeding dysfunctions, immune difficulties, and psychiatric complications. So certainly a whole host of issues associated with cocaine use in the elderly. And then last would be prescription medications. And this is where I think it's very difficult for the elderly population to wrap their head around some of their prescription medications and the risks that can be associated with them, especially when we're dealing with opioids or pain medications and benzodiazepines, which are medicines typically used for sleep and also for anxiety. These medicines all have significant drug-drug interactions with the majority of the medications that we use to treat illnesses such as high blood pressure in the elderly, or even diabetes. These medications can interact with those medications as well. And one thing that as a psychiatrist, one of the number one complaint that we hear typically is that I'm having trouble sleeping. And this is very difficult in the geriatric population, especially those in their late 70s, early 80s that want to sleep like they did when they were in their 20s or 30s. I always try to educate people that, as they get into their 70s and 80s, our sleep changes, and it's a normal part of aging where we don't sleep for extended periods of time at night. It's very normal to maybe sleep for 2 hours at a time and take naps during the day. At night, waking up frequently at night. When we try to fight that and get a sleep that is something that we may have had in our 20s or 30s, where we sleep 8 or 9 hours at night continuous, oftentimes, if that's the expectation of the patient, medications that are very powerful, like benzodiazepines, medicines like Ativan or Xanax or Valium or Librium or Ambien can be used, and they can increase our risks in patients over the age of 65 for falls, as well as cognitive impairment. So we have to often educate our patients about proper sleep hygiene and not relying on medications to artificially put our bodies to sleep, especially when the natural aging process for people in their 70s or 80s is not to sleep for 8 hours continuously throughout the night and be awake all day. So prescription medications are always very dangerous in the elderly population. Like I said, the two major issues are falls, which can be life-threatening, as well as the risk for cognitive impairment. Psychiatric complications, certainly studies have looked at psychiatric comorbidities in regards to substance use, and they found high rates of depression, affective disorders, whether that be bipolar disorder or other mood disorders, anxiety, PTSD, sleep disorders, and then antisocial personality disorders. Antisocial personality disorder is typically, what we'll see in a jail population of people that have intersected between substance abuse and the legal system. Screening and diagnosis. This is very difficult in the elderly population, and the reason being is that a lot of the effects that we see from long-term substance abuse in the elderly population mimics what would be normal illness. So, for example, we may have somebody that comes into our office that says that they're having trouble with their memory. And it's very common for physicians or therapists or nurses not to think about substance abuse or have that bias that older adults do not use substances. And we may feel that this may be the early onset of a cognitive disorder, where in fact it may be a substance use disorder that we don't ask about. And if anything, from this talk, it's really to ask the question, have you been struggling with a substance abuse issue? Because often, for various reasons, we may not ask that question. In addition, abnormal sleep patterns. We talked about that as well. Alcohol, marijuana, cocaine, prescription medications can all alter the normal sleep rhythms for individuals. And we may, once again, diagnose somebody with a sleep disorder and prescribe a medication that's highly addictive in order to treat it, but actually just be contributing to their substance use issue. We also see, gait impairment. So we may say, okay, somebody's having a slow gait or a shuffling gait, and may associate that with something like Parkinson's disease, where in fact we may be dealing with brain illness that's associated with chronic substance use. And a little bit about treatment. Certainly highlights the importance of treatment, and then also the deficits that we see in treatment currently in our society. Substance use disorder treatment among older individuals age 50 or more increased from about 4% of the substance abuse admissions in 1995 to about 6.6% of all the substance abuse admissions in 2002. And then that jumped in 2009 all the way up to 12.7% of the substance abuse population. And that once again continues to grow into the 20 percentile where today 20% of our admissions are related to older populations in any substance abuse facility. It results from a 2012 national survey on drug use and health showed about 4 million older individuals in need of substance abuse treatment. And the difficult part of that is that when you're treating patients that have substance abuse in the geriatric population, it can be helpful that they have their own track that's specifically designed for the issues that they may be dealing with, as opposed to some of the younger generations. And it's been estimated that only about 18% of current substance abuse programs in the United States have a geriatric track. So it's certainly an underserved, population in that regard. There's some policy implications as well. We've heard of the Affordable Care Act and how that's been helpful in many ways, promoting mental health and substance abuse treatment. However, every session and with the political climate the way it is now, it's always brought up whether or not that's something that may be repealed. And that would have catastrophic effects for the substance abuse population and mental health population, especially in the geriatric world, where 65% of the population, 100% of the population is likely going to have Medicare. So the Affordable Care Act and the way it impacts Medicare is significant in access to treatment. I left with just a little joke. It's not a funny topic, but so anyways, I just wanted to say thank you again. And I wanted to kind of get through some of the slides so we'd have some time for discussion. Any type of question that you may have, or patients that we see in our office, please feel free to ask me about. Or
I think I have changed the settings so anybody can unmute themselves now. So if you have a question, let somebody try it out. Let's make sure it's working. Melanie, can you unmute yourself?
Yes.
Okay, great. Do you have any questions while you're here?
I do not.
Well, I have a question. I'll start with a question, Dr. Ferraro. I've been reading and hearing a lot about the use of hallucinogenics and microdosing for PTSD and ADHD. Very interesting stuff. What could you share with us? Like what you're able to share, how if you think this is valid research, if you think there's that there may be some help for it and some individuals to qualify, et cetera.
certainly, I mean, so we'd be specifically talking about some of the clinical trials that are going on relating to psilocybin, which are psychogenic mushrooms, LSD, ecstasy, which is MDMA, and even ketamine. So those are all considered to be class 1 drugs, and they're being used in research settings. And the results, from a lot of the studies that are being done in the VA are promising. But one of the things that, especially in psychiatry, we're just at the beginning of this research. This research started in the 1960s, and then it really fell out of favor for the next, 30 to 40 years. And within the last 5 or 10 years, we've seen kind of an explosion in this. So certainly I would say that there are benefits, specifically I can talk about MDMA in PTSD. That's been studied in the VA. But it's not MDMA in the sense that you go to a psychiatrist and they give you a 30-day supply of MDMA. Typically it's 1 or 2 sessions where they use MDMA and discussing trauma, and then that's the end of the treatment. There's always a slippery slope in medicine, and I think sometimes there may be some outside influences, especially in the pharmaceutical company, that could make this something that could be potentially dangerous to the population. For example, ketamine. When ketamine came out for depression, it was done in hospitals. It was done for treatment-resistant depression. That was given IV, and also there's a nasal spray called esketamine or Spravato that can be used for depression. But these were supposed to be administered by a physician in an office for a brief period of time. Unfortunately, I've seen throughout the country that this is something that's now being prescribed for people to be taking on a daily basis. And there really isn't any literature on that. But so the fact that these substances are being studied, I hope that they'll be regulated in some way so that it won't be kind of indiscriminate prescribing of these substances without any type of close monitoring. And I would speak also for, I guess, the explosion of medical marijuana. I certainly see a lot of geriatric patients that, in Florida, there's supposed to be 8 conditions where you can receive medical marijuana, but there's a 9th condition, which is other medical illnesses. And that's a wastebasket that I think pretty much anybody in Florida could fall into. And when they go to the medical marijuana clinic, because there isn't very tight regulation on it, or as tight as it maybe should be, I think a lot of people are getting medical marijuana and having adverse outcomes as a result. I see many, not just geriatric patients, but I see a lot of college students that have first episode psychotic breaks with medical and recreational marijuana. And then I've seen several of my patients have fairly significant cognitive issues as well as falls with kind of the over prescribing and not very judicious prescribing of medical marijuana.
So can I ask sorry, I have 2 questions. One, you were talking about the medical marijuana, and I'm glad you brought that up because I guess the anatomy of an older individual is changing, and then talking about doing the medical marijuana, because I know, like my thinking is, like my father, who's in his 80s, has back issues. He's on an opioid for pain medicine, and I'm like, why don't you try this? Why don't you try this? But it's interesting you mentioned the kind of the contraindicators of what could happen. So I hadn't really thought about that, as I think everyone uses medical marijuana and it seems to help, but really understanding the different issues.
I think it's important to talk with your doc. I mean, when you're looking at treating chronic pain with opioids, the people that need opioids for the treatment of their chronic pain, or comparing that to medical marijuana, there's a lot of very good literature that talks about the relative safety of medical marijuana. But unfortunately, sometimes I see just in practice that those discussions aren't really had with the patient about the potential risks or things to look out for with medical marijuana. A lot of the appointments are, done via telemedicine, and you may see the doc one time for 30 minutes, and it's not an ongoing relationship that you typically have with a medical marijuana provider. It's something maybe happens once every 3 months or 6 months. So a lot of things can be missed, and I just want to, I guess, caution people that there are complications with the use of medical marijuana. With that being said, we've certainly lived through the opioid epidemic that's still going on, so that's not a great option either. So it's a very, very complex question. It has to be individualized to that patient.
Right. So my other question about detoxing over at Capital Regional. So I know we're talking about 65 and up aged, but what over at Capital Regional, is there a certain percentage you think of patients that are detoxing over there, or what percentage might be in this elderly population, or what are you seeing?
I'd say that at any given time at Capital Regional, being not a very large academic medical center in a large urban city, but it may have between 8 and 10 patients detoxing from alcohol, benzodiazepines, methamphetamine, cocaine, opioids at any given time. And I would say that it wouldn't be unreasonable that if we're going to include 60 and above in this population, that about 25%, maybe 20 to 25% may be in this population. So it's a fairly significant amount.
Yeah, sounds like it.
And a lot of times, unfortunately, the patients will come in with confusion or acute mental status change, and they'll be admitted to the medical service. And it may take 2 or 3 days for them to really figure out that they are actually withdrawing from a benzodiazepine or alcohol or an opioid pain medication. And we may get consulted for agitation and then find out later it's a substance issue.
Because they're having withdrawal symptoms that might be identified. Interesting. Thank you.
I thought your list of risk factors was really interesting. Melanie, you probably thought about that too. It's almost identical to the risk factors for isolation and loneliness, or the risk factors for substance abuse. Just something to think about. And when you think about older people and abusing substances, like younger people, right? They're getting them on the street. They're buying them from somebody. Where are older people generally accessing these substances or that they're abusing? Are they just misusing medications they have? How are they getting them?
It varies. It's amazing. It's a lot. When I was doing primarily addiction work, you would see it. There's certain doctors in the community that have been kind of pinpointed as people that may be more likely to give out controlled substances. So there's certainly the physician element that will be giving out controlled substances. People in assisted living facilities are notorious for sharing their medications for a price. So there's a kind of an underground network in that world as well. And then you have people that have had longstanding histories, maybe living in the same town for many years, longstanding drug histories that have just kept up those contacts throughout their lives. So, but I would say that it's mostly, well, not mostly, but there's a significant percentage of the elderly population that are being legally prescribed these medicines by physicians, and maybe overusing them or supplementing them with somebody else's supply.
I would like to ask a question. I was really struck with your information on all of the complications that can happen from marijuana use in the elderly, and especially the cardiac effects. And with everyone being concerned about, cardiac illnesses and death, I just feel like there's a lot of people out there that probably have no idea of that. Maybe that could be a problem to them if they have cardiac problems. And my second question I wanted to ask was, do you find that a number of people who've never smoked because they weren't interested in smoking for health reasons, but now they get the medical marijuana and smoke it, or do they generally get it in other ways? How do you see that happening?
Yeah, there's been a lot of interest. Well, to answer the first question in regards to cardiovascular risks, one of the things that is interesting, in the late 1960s, the amount of THC that was actually in marijuana is, the amount of THC now compared to then is about 8 to 18 times more potent. So all of the side effects that we may or may not have experienced in the 1960s are going to be heightened because it's just a lot more potent product, especially when you get into the medical realm where you know exactly the amount of THC that you're being given. And you can adjust your prescription for higher THC content if you want to. So that, once again, will increase the burden for cardiovascular issues or cognitive side effects or risk for falls. So that's something that needs to be closely monitored. And then the second question was in talking about, can you just refresh my memory on that one?
Yeah, well, a lot of people wouldn't be smoking through their life in the last decades because of health concerns about smoking, but now that would be the primary access. I realize there's all kinds of edibles and things, but how are they taking it in?
Yeah, that varies too. I would just say in my patient population, it's probably 50-50 people that use the flower and inhale the smoke versus those that use some sort of edible or tincture of some sort. Um, there is some interesting data on marijuana use and the effects on the lung. And it's conflicting. Some articles say that there is no increased risk for any type of cancer. Other people say that there may be a slight increased risk for any type of lung cancer associated with marijuana smoke, and we really don't understand why that's the case. There's actually data, a huge VA study that came out about 7 years ago that talks about improved lung function in patients that smoke marijuana compared to people that do not. So it's interesting because we really don't know the answers as far as the long-term side effects of chronic or of marijuana usage, especially if it's recreational and it's not chronic and daily use. Chronic daily use, we do see declines in pulmonary function, but the intermittent recreational use, that hasn't been proven yet. So it's certainly not as in the most recent literature that is dangerous as cigarette smoke. So that maybe give people some or less hesitancy to inhale the marijuana smoke.
Have you seen any?
With that being said, there's always differences in absorption with drugs. So people that inhale something are going to feel the high much more quickly, and it's going to wear off a lot more quickly. What can happen, which can be very dangerous for the elderly population because they have higher fat content and they're slower to metabolize and they're slower to digest, is they may take an edible and not feel anything. And then in a half an hour, say, well, that didn't do anything, I'm going to take more. And then the next thing, it builds up in their system, and then they have falls, and then they have all these other types of issues because the edibles are going to take a lot longer, especially in the elderly population, to feel an effect.
Have you seen any incidences or unfortunate sequelae or impact from the use of Delta8?
I don't have as much experience with the Delta8 just in my own population, but it is very similar to THC, that molecule. So and the thing that makes it even more dangerous comparing it to medical is it's not regulated in any way. So that I guess all Delta8 is not the same. It's hard to know exactly what the potency is, especially when you're getting it at a gas station or a head shop or something of that nature.
Kratom. Do you know about Kratom? What is that?
Kratom. Yeah.
Kratom. Yeah.
Yep. It's a substance that has benzodiazepine-like qualities. It's initially thought to be helpful in patients that were wanting to come off of opioids. But we routinely see, usually it's a younger population, in their 20s or 30s that are abusing Kratom. But it will give you a mild euphoria mixed with some sedation or anxiolytic property.
Totally legal too, right? Just
currently, it's one of the things, it's like spice or K2 or synthetic marijuana. That used to be legal and sold at gas stations, but Kratom is one of the things that the DEA is looking at as far as whether or not that's going to be regulated.
Do you think that there's an attitude around seniors with, physicians or families of seniors that may be misusing their medications that was just like, oh, well, they're old anyway, or just let them have their fun or whatever? Do you think that that's prevalent? And
I think you probably see it on both ends of the spectrum. You may see it in your 18 to 25-year-old generation, as well as your maybe 70 to 80-year-old generation, where like you said, it may be that they're not harming anybody. They're not. They're in their homes. They're not going out and doing as much. There may be that bias that it it's not as harmful. I would suggest that it is. Even though they're not interacting as much potentially with the outside world, they still could be struggling with significant anxiety and depression and self-medicating. And then we also see that on the other end of the spectrum, I think with the 18 to 25-year-old population, that, kids will be kids, and, they're just kind of experimenting, but not really highlighting, how dangerous the substances that we're using now are, especially with all of these synthetic drugs that are out there. A kid that could go to a party and get something from a friend and have no idea that it's laced with fentanyl, and that could be a lethal night for them. So the experimentation that was done in the 60s and 70s is very, very different in regards to the lethality of what's on the street now.
Did you all see Nicolette's message in the chat box? She's sharing a resource, Flip the Script Pain, information about safe medication use, talking to a loved one. Can you all see? If you haven't checked that out, take a look at that.
And also, I think Judy has had a question as well.
Just when I worked in a geriatric clinic, we saw so many, usually elderly ladies, who had their nerve pills, and you were not going to separate them from their nerve pills. And so I wonder kind of how you address that. And also just in general, do you use kind of an AA treatment module, or do you have different treatment modalities that you use?
You're exactly right. And it really coincides with Valium coming out on the market in the late 60s. So Valium is one of our first benzodiazepines, and it was marketed as, what they called at the time, mommy's little helper. It was marketed towards, 25 to 35-year-old women that were under stress. And unfortunately, until recently, we really haven't looked at benzodiazepines the way that we look at them now. So there's an entire generation, and it really is the baby boomer generation, that have been on benzodiazepines for maybe 40 or 50 years. And it's almost impossible to have somebody walk into your office, unless they've had significant issues recently with the medicine, to say, I want to come off of the medication. So I usually use, just basic motivational interviewing and see if there's anything about the medication that they're taking that they would like to change. And then that's usually where I start with. So, I'm feeling tired, or I don't have enough energy, or I feel sluggish, or my cognition's not where it wants to be. And I said, well, let's talk a little bit about the Valium or the Ativan or the Xanax that you're taking, and see, would you be, and I always say, would you be willing to see if another medication might be as effective and not have as many side effects? And then the key is to reduce the medication over the course of 3 to 6 months. Anything that's going to be abrupt is going to cause withdrawal, and they're automatically probably not going to see you again, and want to increase their dose because they're feeling like their panic has come back. So it's really just, basic motivational interviewing, kind of meet them where they are. If you can incorporate or, bring another family member in, that can also be very helpful. A child or a spouse that may see some things in their partner that, or their parent that's concerning. Because a lot of times, like you say, if you've been on a medicine for 40 or 50 years, it becomes a security blanket for a lot of people. And another thing, just in general, is that the primary care physicians across the country are now, because there's a black box warning on benzodiazepines for patients over the age of 65, for the risk for falls and cognitive issues. We get a lot of referrals just because primary care physicians won't prescribe these medications for the elderly population. So you may have had a doc that you've been seeing for 30 years, and that doc retires, and you get a young doc that was trained not to prescribe benzodiazepines, and then you're being forced to see a psychiatrist to prescribe the medication. So we see that routinely in the psychiatric world, that we're being referred people, sometimes even just on very low doses of medicines, just because the primary care doctors won't prescribe them.
Are baby boomers in general more amenable to mental health care than, say, the greatest generation was?
Oh,
Just-
certainly. Yeah, I mean, a lot of, I think a lot of the baby boomer generation were still in the workforce when computers came out. And so that allows, for significant education. A lot of, baby boomer generation, I think, was the first generation. Because I can remember when I was first starting off in practice and I was treating the greatest generation at the VA. And I wouldn't say all, but the majority, okay, whatever you say, doc. And, I was a 26-year-old and, they just kind of trusted the establishment or the physician or the nurse. I think the baby boomer generation, just by nature, through everything they lived through, is more informed and wants to make their own decisions regarding their healthcare, which is good. So that I certainly think that there's just been a change, and part of that is also expressing their feelings, which the greatest generation were really not told to do so. So, and it's actually, from my experience working at Florida State University, it's amazing to me how many college students and even younger are very comfortable talking about their own mental health issues with their peers. Whereas even in younger generation or older generations like Gen X, that wasn't something that was ever done or rarely done. So I can see a fairly dramatic shift over the last 20 years.
Hi, this is Nicolette. I think that there's a lot of opportunity for the medical profession to help gain patients' trust in mental health care and substance abuse treatment, because they really have that trust of older patients. Dispel some of the myths of what it means to go get therapy or go get treatment for addiction. I think there's a lot of misconceptions from the media and how it used to be done 40 years ago. So hopefully we can keep moving in that direction. But thank you so much for all this information.
Oh, well, thank you. Thank you for having me. And
this has been wonderful. Really great information. You're a really good speaker. Really appreciate your taking the time to spend with us tonight. Are there any last minute questions? Well, I'll just say thank you so much. And thank you to everybody who.
Harold has his hand raised. I don't know if you can see that or not.
Oh, he does? Okay.
Oh, yes, ma'am.
Where is he? Oh, there he is. Okay, Joe, I guess.
Oh, I'm sorry. Here we go.
What do I do? I'm going to ask you to unmute yourself. There you go, Harold. If you unmute yourself, you can ask your question.
Okay. As far as substance abuse and self-medicating goes, I'm a veteran care coordinator at 211 Big Bend and work with a large population of Korea, Vietnam, and some World War II, all from World War II on. And with the shakeup in the mental health care system, a lot of veterans have been established with doctors for a long time, and with the turnover in the VA, then all of a sudden their doctor's snatched away, their medication is shaken up, and then they turn to self-medicate. But through all the substance abuse treatment and the mental health treatment, how much is any of this geared toward getting at the unresolved trauma behind the addiction?
certainly, I think that would be the what we try to do at Capital Regional through our intensive outpatient program is to really kind of get at what are the motivating factors, for somebody to use a substance. I always, try to make it pretty simple and asked the patient, I said, there's 3 types of people that use drugs. I said, people that are trying to numb themselves from an emotion, people that are trying to feel an emotion or feel better, or people that are trying to do both. And essentially, you've got the people that are numbing themselves, and I think that does resonate with people, because people say, yeah, I'm numbing myself. Okay, well, what are you numbing yourself from? And then you get into all the different issues that you may need to work through with that individual patient. Or you may have somebody who says, well, I'm trying to feel good, and it's really the same answer to a different question. But okay, so you're trying to feel good, or you're trying to feel alive again, or you're trying to do something that you're not able to do. Okay, well, what's preventing you from living the life that you want to live? So you can ask those kind of open-ended questions, and it allows them to kind of talk about what they're going through individually. And then any great substance abuse program is going to have therapists. And they're going to work with them not only in a group but individually on their own specific issues. So and you're dealing with the VA population, which is a very challenging population, because they're struggling with a lot of psychosocial issues, trauma, as well as a history of substance abuse. So that's a very difficult population. A lot of challenges there.
Really appreciate that you're here tonight, Harold. He's with Big Ben 211, which is, of course, a very important mental health resource in our community. I got a cryptic message from Christy earlier that 211 was there, and I didn't know what she was talking about, but now I know what she meant was that she gave you the link to be here tonight. So thank you.
And I think
There's
Richard
one
might
more
have
hand
a
up.
question.
Yeah.
Yeah, he's got his hand up.
Hey, Richard,
yes,
can
ma'am.
there you go.
Yes, I'm here. I had one quick question. In the Capital Regional Medical Center's programs, both inpatient and intensive outpatient, what kind of modalities are used? As in particular, is the AA 12-step program a big part of those treatment modalities, or do you not really use something else other than that?
Well, Dr. Knoll runs our program over at Capital Regional as far as our IOP. We're working, as hard as we can to develop a detox program at Capital Regional. We have one within the hospital on the medical floors, but we don't have one on the psychiatric unit yet. So I can't speak to the detox component, but Dr. Knoll uses a lot of the AA principles in his treatment. It's just one of the modalities that he does use. Uses a lot of DBT principles as well, in regards to mindfulness and recovery. But the thing that's nice about AA for patients that like AA is that it's accessible, it's free. There's many good groups here in town and all across the nation. So if a patient has an interest in that form of recovery, it's something that they'll be able to have access to. So we certainly would be strong proponents of that treatment, but that is not exclusive to AA.
Any other questions? All right.
Yes, I'm sorry. I have one more. With another trend that we've noticed while we're doing outreach is computer literacy, with the senior population having difficulty using the modern electronic devices, and with the limitations on COVID and the comorbidities involved with them, they're kind of timid about going out. So how can services reach them? Is there a telehealth component or some other type of outreach service they can partake of?
At Capital Regional right now, we do not have the ability to do the telehealth in our outpatient group. And then the other service we offer is in the hospital. But I do know of several therapists in the community. In our practice, the majority of the large psychiatric practices in Tallahassee and large therapy groups in Tallahassee are all offering telemedicine services at this time. And, you know, if you're talking about, you know, access, you know, in my patient population, which I'm doing a lot more inpatient now, but long story short, for my outpatients that aren't able to figure out the computer, I'll just call them on the phone because they're, like you said, they're afraid to leave the house. I don't expect them to come into an office if they're not comfortable with that. And if they can't figure out the computer, you know, we'll give them a telephone call. So it's not ideal. You know, this is a unprecedented time, and hopefully, you know, we can get back to normal in the nearer future. But I found the telephone to be very effective and well received.
Awesome.
I see we had one person who just joined us very late. The name is Denies, and I wonder did you have a burning question before we sign off? You'll have to, let me unmute you.
My name's Denise.
Denise?
Yes, no, I just wanted to listen in, see if there's anything new going on.
Well, we did record this, so you will be able to watch the whole thing on demand on the Senior Center's Foundation website at a soon later date.
Okay,
Okay.
thank you.
Okay, well, thank you for joining us. All right, everybody. Well, thank you so much again, Dr. Ferraro. This was just fantastic.
Well,
Yeah.
thank you for having me. I appreciate it.
Thank you, everyone who was here. Y'all have a good evening.
You too.
Okay.